All right. Well, I'm going to lead off here, and we'll tag team with Kristen to some extent. I apologize that I'm not able to be with you there in person. I certainly would like to be able to do that, but duty called me to a different city today, so we're kind of doing as best we can with all of this. And I'm going to start on slide 2 of the deck, which shows the ACO vision as articulated by CMS. So this is a set of points that Jonathan Blum and other leaders over there have been putting forward for some time. As you can see, it's very ambitious and reflects a notion of basically a direction here. They're not so ambitious as to think this is the only direction, but a direction for reforming the fee-for-service program in a very serious way. Just for sake of framing comments, there are about 42 million beneficiaries in the Medicare fee-for-service program. Those individuals have free choice of provider. Providers are paid according to the well-known Medicare fee schedules and the respective payment systems of the various sorts. And both of those ideas have come under some serious assault lately, particularly the latter. So this is an attempt to move into that environment with techniques that are similar to those that might be used in a managed care environment, but preserving certain major flexible elements of fee-for-service. On slide 3, you can see the different projects that CMS has announced and is moving forward with at present. So they are talking about creating multiple pathways that are to some extent tailored or can be tailored to fit the readiness of various organizations to participate. MSSP stands for the Medicare Shared Savings Program. That's a statutory program. That's an ongoing part of the program. I'll come back to that in a couple of minutes. And there are a couple of tracks, as are noted here, within those two. The Pioneer model is much more for shovel-ready kind of organizations, and that is regarded, as the name suggests, as the people who are going to be out breaking the trail in terms of new and even more improved ideas that may then cross-pollinate, cross-fertilize with the MSSP program as time goes on. The advanced payment model is essentially a subset of the MSSP that allows providers who are participating in the MSSP to receive a certain amount of funds in advance to help with startup costs, but it is not really a distinct and separate model. On slide 4, you can see what CMS, again, I've taken this from them, articulates as guiding principles for these ACO initiatives. So multiple pathways, multiple ways to get into the system, but people who are prepared to run a faster race have an option for that, and those who are only figuring it out slowly can elect different models. They emphasize data partnership, of being able to give data in a very rapid way to the providers about what is going on with their caseloads so that they can see and figure out what's going on. There's a strong emphasis on beneficiary notification and on beneficiary engagement. Again, this is a fee-for-service model. The beneficiaries deserve to be informed about what's going on. They do not enroll, so they are not making an election to do this or not do this. That is to say, to participate in the ACO or not participate in the ACO. But nonetheless, the ACO is supposed to make sure that they're aware of what's happening and is supposed to be engaging with them in terms of trying to make them as a full partner in the care processes in various ways. CMS will be maintaining strong partnership with the federal antitrust agencies, the Federal Trade Commission, and the Department of Justice. There are no sort of blanket waivers available in the antitrust sphere, and that may be a concern for some provider groups in some local areas. In order to make this all work and make sense within a fee-for-service environment, you really have to measure quality very carefully so that you do not create an incentive simply to save money and thereby to stint on care or provide inappropriate care. So robust measurement of those items is important, and monitoring by CMS to a greater extent than fee-for-service providers are used to. In their final rule, CMS very explicitly moved to create a stronger business case for participating in the ACOs. The proposed rule, for those of you who've been paying much attention to this, sort of dampened down a fairly substantial amount of buzz and enthusiasm that was common in the community prior to that time. Everybody looked at the proposed rule and said, "Hey, wait a minute, this isn't nearly as good a deal as they thought it was going to be." CMS, in large measure, listened to those concerns and made improvements in the final rule. It does not make it perfect, but improves the possibility that people are going to want to participate and that will work. Moving on to slide 5, you see the common features that are in CMS's models announced to date. Now, I should pause here just for a moment. We talked about very briefly about the MSSP model, which is the principal one we should be concerned about. The Pioneer model is moving actually on a slightly faster track. CMS has actually said that it intends to introduce yet more models in the future using its demonstration authority. So they mentioned dual eligibles, for instance, as one area which is likely to receive some attention. Those initiatives have not yet been announced, but are sort of on the shelf. Well, they're not on the shelf, but they're coming. They're being hatched back at headquarters, and will probably share many of the same characteristics that are noted here. Characteristics, principally that you're working with a population that is essentially assigned to you on the basis of the primary care use. In the primary care, or in some circumstances, the specialty, primary care services delivered by primary care providers, or in some instances by specialists within the ACO's network. Those beneficiaries, as I mentioned earlier, are not locked in. This is not like HMOs. You don't get to decide where they're going to go for care, or even create substantial financial penalties as in a triple track model for going out of network. They get to choose any fee-for-service provider, and CMS emphasizes that very strongly. It's rooted very firmly in the statute. Emphasis on quality improvement, quality measurement, as I mentioned earlier. It does afford the providers who do well in this environment the ability to share in savings to Medicare. These two bullets go next to each other. So you have to achieve reasonable levels on the quality measures in order to get into the game for savings. If you don't get good quality scores, no savings. There's a strong emphasis on IT. It is not a requirement. There were, in the proposed rules, requirements related to use of electronic health records. They've eliminated those as a requirement in the final rule, but they have double emphasized them in the quality world. So I think that it would be fair to say that they regard health IT and EHRs in particular as really critical to make this happen and make it work well. And I think most observers who looked at it would tend to agree with them. They provide some, in consultation with the Office of the Inspector General, they provide some limited waivers of various of the anti-fraud laws. Kristen will speak about those in a couple of minutes. And as I mentioned earlier, there's scrutiny of all of this under the antitrust laws as well. Okay, so just to, since these beasts may be active in your environment, even if you're not directly participating, I thought it would be worth it to present you just a little side-by-side comparison. I'm now on slide 6 of the two models. Shared savings, the Medicare Shared Savings Program, or MSSP, is on the left side and the Pioneer model on the right side. Important point about the shared savings model is it doesn't go away. It's not a demonstration. It's an ongoing part of the program. It's being managed out of the part of CMS that also runs, for instance, the home health perspective payment system, and not out of the demo shop. It's an enrollment model, so as long as you meet the basic characteristics and qualifying requirements for this, you get to play. It's not limited in terms of the number of entities. CMS has estimated that the number of entities that might participate in the first 3 years might be between 50 and 270. remains to be seen what will actually come of all of that. There certainly is a lot more interest this month than there was 6 months ago in all of this. Both of these center on primary care providers. They do have some opportunity for assignment of beneficiaries to be made on the basis of specialty care in certain circumstances that may be a little clearer under the Pioneer model. But we're not entirely sure what the Pioneer model is going to actually look like when it's on the ground, because they haven't announced the winners or exactly what's going on with that at present. Shared savings is a little bit smaller in terms of its minimum beneficiary requirement. And in both instances, providers are paid under Medicare fee-for-service. This is an important point to recall. The ACO is not coming around and doing a deal with providers saying, well, I want you to give me a 10%, 20% discount. The payment is still coming out of the Medicare administrative contractor at the usual rates, although in the Pioneer model they do introduce a notion of partial capitation one of the later years. Moving on to slide 7, a couple of key points just to help you navigate, help you think about these ACOs as they emerge in the environment. First of all, I've sort of emphasized a couple of points already. These are not like HMOs. So you need to kind of detach your thinking from, oh, this is just another variant on the HMOs. Patients are not locked in, and the payment is on a fee-for-service basis. The emphasis of achieving savings is savings to Medicare. Those are the savings that are shared back to the participant. And in order to do that, you largely have to work in terms of service use, working on clinical protocols, changing referral patterns, and care paths. That may be actually an angle where home health agencies have a distinct advantage because insofar as you are able to take care of beneficiaries that might otherwise be put into institutional settings, IRFs or SNFs, at home at lower cost to Medicare, that may make your services attractive. I've really already spoken about much of the balance of the slide here, so I'll move forward. On slide 8, coming back to the point of how many of these are likely to be, we don't know. My watchword for a good while has been they're not going to be like Starbucks. You're not going to see them popping up on every street corner. They're really kind of tough to organize and put together. The final rule breathes new life into this environment. And CMS has lowered the lower bound estimate of what it expects might be possible to 50, raised the upper bound to 270, but would be the first to say they don't really know. So this is with less reliability than their usual actuarial estimates. Other ACOs may come along, as I mentioned a moment ago. A wild card in that is the departure of Don Berwick, the incumbent administrator. He is term limited and will be leaving his current job at the end of December. He can't be reappointed to that job. Whether he will be asked to stay on in some other capacity in the department, perhaps a senior advisor on innovative matters or something of that sort, remains to be seen, or he may return to his teaching post at Harvard. He's obviously been a spark plug and key intellectual leader in this entire enterprise, and remains to be seen what will happen once he's no longer in the executive chair. And then the final point here is that this isn't just a Medicare kind of thing. ACOs, any among around the table there could go set up an ACO this afternoon. You don't have to be a Medicare participating ACO. And private insurers in a number of cities are doing deals with providers, setting up ACOs. We're active, our firm is active in a little bit of that work as it is. So in this is a place in which the private sector, at least at the moment, is probably actually out in front of Medicare in terms of its development. There's an interest on Medicare's part, incidentally, in looping that together and making, getting to a world where ACOs are participating with private insurers and with Medicare beneficiaries at the same time. That would obviously provide some advantages in terms of spreading overhead over larger populations and otherwise other advantages of scale. So we may see more of that in the future. In the Pioneer model, for instance, they basically insist on it. The changes from the proposed rule, for those of you who may have dipped into that and gotten a bad taste, just summarizing very quickly what those are. There's an advisory that we have available on our website. Kristen can give you information about that if you need be, that highlights the major changes in the rule. A significant one is that ACOs do not have to go at risk of paying back the government if there are losses. Remember, this is a shared savings program. In the proposed rule, CMS said shared savings are fine, but by the way, we want you to share in losses too, at least under some circumstances. That created howls of dismay from provider community, and that idea disappeared in the final rule, as did a couple of other ideas. So that on the financial side, I think it is definitely an improved business case here. There were some changes in the methods by which beneficiaries are assigned. They're a little bit intricate, but the basic idea is that ACOs will now be able to identify upfront those beneficiaries which are likely to be assigned to them over the 3-year, over each year of the agreement period. It's only at the end of the year that there'll actually be kind of a reconciliation, and it will be determined exactly who are they going to pay attention to. So that insofar as beneficiaries leave your network because they're moving to Florida or something of that sort, or moving back up north if you're in Florida, ultimately you would not necessarily have to be accountable for those. So they have greater flexibility in addressing those kinds of questions, and also allowing providers to know who they're dealing with, which is thought to help a whole lot in terms of beneficiary, if that's indeed one of the goals, which it appears to be. The number of quality measures, again, some howls of dismay coming up from the provider community. CMS went in the back room, took a real hard look at what was going on there, and reduced the number of required quality measures from 65 to 33, and I believe Kristen has a table available for you there that shows what those taken from the final rule. Those of you who are interested in this, there's a rather full discussion in the preamble to the final rule about what they did and why they did it, which can repay some attention. The general notion, I think it would be fair to note here, however, is that CMS notes that some of the measures that they had in the final rule they're not requiring, but they will be using for monitoring. And I think it would be a reasonable expectation to think that CMS is likely to adapt and likely expand the number of required measures over this project, over time on this project as it develops. But in the first year, it's at this more gentle level. A few other changes here. Mentioned health IT already. Eligible entities, now they found a way to bring FQHCs and RHCs into the club so they can be the center of an ACO. Marketing material on a file and use basis, which is thought to be of some advantage, I think. Antitrust, there's some streamlining in the procedures, but they're still subject to scrutiny by the antitrust agencies. This is a hidden bear trap, and people who are interested in forming ACOs or participating in ACOs that are being formed need to be mindful of this, because insofar as you have a large market share in your local area, you could trigger concerns, and the antitrust agencies also articulate a set of practices that you're supposed to watch out for. Anybody who follows antitrust would say, oh yeah, these are not surprising kinds of concerns. But this is not a ticket to get away from those kinds of issues in terms of sharing information. On slide 11, still things to be concerned about here. The picture is better. People involved need to be assessing. I'll come back to that at the end of the presentation a little bit. Need to be assessing whether they want to come play or not. The beneficiaries still have free choice, so you don't get to determine what they're who they go see once they have, for instance, an acute care episode. beneficiaries can opt out of data sharing I was speaking about earlier. Some providers may regard that as a significant problem. CMS leadership says it really doesn't expect much of that to go on, but they felt it was a valuable protection for beneficiaries and needed to offer them that opportunity. Noting toward the bottom of the slide here, these things are expensive. CMS is, in its doing up its calculations on this, assumed that the startup costs for an average ACO would be just a little bit north of $500,000, and the ongoing cost would be something in the neighborhood of $1.3 million a year. Now, that may vary a whole lot, but you do need to recognize there are some really important costs that need to be met. That if you were participating in ACO, you would need to be helping with the ongoing costs of that. Presumably, these costs are paid out of shared savings, so one has to look at the possibility that you're going to get shared savings, and it's not sure. So this payback is uncertain. There are examples of some of the demonstration models which, while they did very well on quality, didn't necessarily do quite so well in terms of achieving savings. And the agreement period, some providers have criticized this because it's only 3 years long, so it doesn't give you that big a payback time. Although these are renewable, it's not a demonstration that you do it for 5 years and it's over. You are perfectly eligible to have a second, third, whatever agreement. Each of these would be approximately 3 years, and so you can keep it going as long as you're doing a good job and CMS doesn't see some room to terminate you. Okay, I'm going to stop for a moment here and turn it over to Kristen to tell us a little bit about the waivers in the fraud and abuse area. Hello?
So, as Tom mentioned earlier, CMS, together with the ACO has issued an interim final rule with comment period setting forth 5 fraud and abuse waivers for ACO. And the comment period closes January 3rd, 2012, and I will get into it a little bit. There may be some things that providers may want to comment on in this. The rule sets forth waivers of 4 of the primary fraud and abuse laws. The START law, which basically prohibits a physician from sending any referred Medicare services to a provider that it has a financial interest in. The Anti-Kickback Act, which basically prevents you from providing any remuneration to anyone as an incentive to refer or purchase Medicare or Medicaid covered services. Or gain sharing CMP, that basically prohibits a hospital from giving anything of value to a physician from referring services to its patients. And the last is the beneficiary inducement CMP, which basically prohibits an entity from giving something of that value to a beneficiary that would incentivize or prohibit the beneficiary from having choice of its provider. CMS and OIG had issued a waiver design notice back when the proposed rule for the ACO was issued. It only had 2 waivers in it. They weren't very broad waivers. We'll discuss them a little bit in a minute, but they basically prevented shared savings portions of arrangements and also certain dark law covered arrangements. But they weren't really broad enough to cover a lot of the operational arrangements between agencies. And I think a lot of the commenters thought that they weren't broad enough to really functionally protect the things that ACO participants were worried about. So they've gone from 2 waivers to 5 waivers. It's really a sea change. So, if you're interested in this, I would really just focus on this interim final. So among the 5 waivers, there are 2 sort of what I think of as umbrella waivers. They are the pre-participation waiver and the participation waiver. The pre-participation waiver, as its name suggests, basically protects arrangements prior to their entering into a participation agreement. They protect startup arrangements, and basically a startup, the rules that waiver, you've got to have a good faith intent to actually become ACO. You need to make, the governing body needs to make a bona fide determination that the arrangement is reasonably related to the purposes of the shared savings program. And then there are, I think, pretty onerous documentation and disclosure requirements that need to be satisfied. And CMS has indicated that these documentation and disclosure requirements are sort of meant as safeguards to make sure that, fraudulent and abusive arrangements are covered. This is the only waiver, as I mentioned, that does not require an ACO agreement. It's re-entering the agreement. Interestingly, this is also the only waiver that does not include drug and device manufacturers, distributors, DME suppliers, and home health suppliers. And surprisingly, in the rule, CMS and OIG actually state that they've chosen to exclude DME suppliers and home health suppliers because they are providers that have traditionally shown a high risk of fraud and abuse. And we would certainly contest that. And also, I think, this is an opportunity for home health providers to comment. We do have a comment period. And I think highlight through the way that this, one, disadvantages home health providers, and also, that they don't pose a high risk of fraud and abuse. Moving on, the waiver basically, just go back one second, sorry. The waiver begins basically a year preceding your application for the ACO program. For 2012 years, it actually starts the date that the rule went out, which was November 2nd. And you can only use these waivers one time. The participation waiver is the similar version of this very broad operational waiver that applies once you've entered into an agreement. Again, it requires these safeguards that must be reasonably related to the shared savings program, the documentation and disclosure requirements. Also, the ACO has to be in compliance with certain government, leadership, and management requirements which are set forth in the regulations under the ACO shared savings. This waiver, in light of it being very broad, it also includes arrangements with providers and suppliers that aren't actually part of the ACO. So, say an ACO has arrangements with health suppliers, for example, or other post-acute care facilities, those sorts of things, they can also be covered under this waiver. So this waiver is can be particularly inclusive of different types of arrangements, and it extends until the end of the agreement and then 6 months past the end of the agreement. There's 3 more. There's a lot of text on this slide. I will just sort of go through them very quickly. The remaining 3 waivers are a lot more specific than the first 2. The first protects the sharing of savings amongst the ACO participants. As you can imagine, that's going to be very necessary. There's one for compliance with START law. I don't think too much of this waiver myself. Basically, it says if you meet the START law exception, we're going to waive the gain sharing CMP and the anti-kickback tax. So it doesn't provide you much beyond what an existing START law exception would already provide you. And then the patient incentives waiver is a waiver for in-kind, so not financial, items or services provided by ACO participants, providers, and suppliers to beneficiaries for free or below fair market value. They need to be connected to the care of the beneficiary, and they also need to advance adherence or chronic disease management. And just, to highlight the in-kind aspect of that, the rule makes very clear that this does not protect the sort of financial incentives to beneficiaries, such as co-pay waivers or those sorts of things. Hopefully the waivers are self-implementing, so you don't need to file or apply for a waiver. You only need to meet one of the waivers to be protected. The waivers only protect ACOs in the shared savings program, including those in the advanced education they're also in the shared savings program. They mention at the end of the rule that they're going to come out with waivers for the Pioneer ACOs and Innovation Center demonstrations. They're under sort of a separate waiver authority. I think the last thing to remember in terms of the waivers is even if you don't fall within one of these 5 waivers, I think it's also important to think of the existing exceptions to the START law, the CMP law, to the Anti-Kickback Act. If you fall inside one of those exceptions, you're obviously not violative of the law. And then also under the Anti-Kickback Act, OIG has set forth several factors that they think makes an arrangement indicative of fraud and abuse, and they tend not to prosecute arrangements that don't fall within those factors. So I think these waivers are certainly very helpful, but it's also helpful to think of arrangements more broadly in line with the law that's already beforehand. Tom?
Okay, back to me. All right. To wrap up here, was going to walk through several slides that would be relevant for organizations that are considering participating in ACO waivers, and some of your organizations may be. Obviously, there's a problem related to the pre-participation arena, and we need to comment on that, as Kristen mentioned. But to look at the sort of considerations that might be relevant at sort of a nuts and bolts and shovel-ready kind of level, one would want to, of course, consider the benefits of participating in all of this. The CMS makes some deal of the efficiencies and improvements in care processes, which would be perhaps a collateral benefit to the organization as a whole, may work to your advantage in local market position, or similarly, failing to participate may work to your disadvantage in terms of local market position. So all of those need to be considered. In terms of cost, here at the top of the slide, I'm on slide 20 now, show you the figures I was citing earlier. Those, again, I emphasize are average figures. CMS makes some comment to the extent that insofar as institutions are involved with these, large hospitals or what have you, they may provide some advantages that might bring down the costs, and that commercial insurance may also, insofar as people are in deals with commercial insurers, that may also provide an opportunity for spreading some of this overhead. The startup costs and the operating costs are noted there at the bottom of the slide. This is not trivial stuff. You need to be able to have robust systems for quality measurement. You have to do a fair amount of organizational work, regrettably having to hire lawyers, all of that kind of stuff in the startup period. Moving on to slide 21, of course, you also have to figure out that you are accepting accountability for the cost and care of a changeable beneficiary population. That's really sort of fundamental. So you look at the costs, you look at the benefits, and then you look at what you have to do, and that's what you have to do. And it's not necessarily an easy thing. Again, I think there may be some advantages that home health agencies could bring to this environment, but you have to assess, I think, maturely and candidly what the real possibilities are for savings. And then you also have to develop all of these things that are shown here at the bottom of the slide. You have to have mechanisms that coordinate care. You have to actually get serious about changing referral patterns, working with evidence-based medicine, engaging with the community, and reporting quality information. Key decisions you may want to consider. This is sort of my list. I'm sure you can come up with others, or if we were at a roundtable about this, it might emerge as a somewhat different list, but here's a starting point for you. Should you participate? It is the case that ACO participants can come to you whether you do or not. Remember, the ACO participants are not locked in, and while an ACO may prefer that their beneficiaries seek services from particular providers, they can't really steer them in those kinds of directions with any great effectiveness. You also need to look at how local referral patterns will be effective. So if there is an a home health agency in your area that perhaps is associated with the hospital that is taking a lead role in ACOs, what's that going to matter? How is that going to matter for you? Who should you participate with? I mean, all ACOs are going to need to consider this. They all need primary care physicians because that's how the beneficiary assignment is done. It has a physician-centric element to this. Hospitals can't do this by themselves. everybody except the primary care physicians is essentially optional. So you can have them with or without hospitals. You can certainly have them with or without home health agencies, skilled nursing facilities, or other groups of providers. And so since the game is to improve quality and decrease costs to the Medicare program in order to have savings to share, which are the cast of providers, which are the particular providers that will give the greatest advantage, maximize the chance of achieving those goals. And you would also need to look at what are the terms surrounding all of this. The shared savings, CMS does not dictate how those shared savings are supposed to be delivered. They ask an applicant for information about what you expect to do. I think they are telegraphing fairly quickly that they think it would be just a really nifty idea if you retained shared savings in order to improve systems, build better quality systems and what have you. But they don't require you to do that. And you would also want to look at exactly how shared savings would be distributed. As far as they're distributed, how they would be flow to the various participants, including you. Okay, moving on to slide 23. I've noted here some of the particular elements that you would need to look at. The application form is out and is on the CMS website at the location that's on the very last slide in this deck. It goes on for about 20 pages. Many of the questions are essentially multiple choice or check the box kind of questions. You either do or do not have a board of directors. The board of directors either does or does not include a beneficiary representative, and so forth. The questions that are shown here are essentially the essay questions. They are asking on each one of these items for a narrative description of what you are going to do. So you, the ACO applicant or potential applicant, would need to be able to come up with an articulate statement about what you were doing in order to answer the question. But of course, you also have to have the real systems behind that. CMS makes clear that even though it's not asking you for voluminous binders of information about exactly what you're doing, you need to have it, and they hold open the possibility of various kinds of audits and of site visits, a sort of demonstration mode to come take a look at what's going on. Slide 24 shows you the immediately applicable time frames. You can see them laid out there. CMS offers two start dates in 2012, one on April 1st and one on July 1st. After that, it will be January 1st of every succeeding year. And there's a run-up to that. And you have to send them a notice of intent to apply. That window for that is open already. It closes after a certain point in January. You have to send in an application by a certain point in January and so forth. And they're going to decide who participates in that first round relatively quickly. So as I said, it's an enrollment model. They're going to look to see if your paperwork is reasonably in shape. And if they have reason to think things aren't okay, they will deny you or defer you. You will have a chance to try to contest that, but the likely outcome would be that you would be deferred until a later period, a later start date, until you had a chance to make sure everybody was comfortable that your ducks were in a line. So that's kind of the outline there. There's a little bit of time pressure if you want to get in soon. The very last slide here shows you some information, resources that would be available to you if you want to learn more about this. The Shared Savings Program website is actually fairly good and complete with a lot of stuff on it. Some of the things that we've mentioned and been talking about here, including the regulations, there are links there to the regulations if you suffer from insomnia and actually want to read these things. The application form is there. They also have a window for questions, and I've actually sent in a couple of questions to this link and gotten answers back. It takes, depending on the complexity of the question, a couple of days to a couple of weeks has been my experience so far, but there at least is that opportunity on a routinized basis to ask questions. They have designated, I will mention here that they've designated in each of the regional offices an ACO contact. So I think that is another resource. I haven't heard too much about people being in touch with those people, but the fact that they put them up there as a list, and you can find out if you're in New York who the person in the New York regional office is to get a hold of, would provide you a channel for getting into some more extensive and detailed questions should that prove necessary. Okay, that's the end of my my formal song here, so I will